So you can see the screen now. We will discuss the spinal cord compression here. The rest of the spinal problems you can discuss in orthopedics. So we are skipping it here. The objectives for this that we'll discuss is spinal localization, clinical presentation, the causes and management of these compression syndromes or the compressions. Just to revise the anatomy, can anyone tell how many vertebrae we have in total? Can anyone tell how many vertebrae we have in total? We have a total of about 33 vertebrae. We have 7 cervical, 12 thoracic, 5 lumbar, 5 sacral, and 4 coccygeal vertebrae. And if we talk about, these are the these make the vertebral column, and in between the vertebral column we have the spinal cord that is that is the direct downward extension of the brain matter, and it contains the nerve tracts that are coming from the brain and coming down till the end of the vertebral column, and they give different nerves at different levels, and they supply the different parts of the body. Now, if we say that we have a problem at the level of the T11, it doesn't mean that at the level of the T11, the nerve affected is the T11 nerve, because usually the nerve, it is arising, or you can say the spinal cord is shortened or shorter as compared to the length of the vertebral column. As the baby grow, the spinal cord grows less as compared to the vertebral column, and usually it ends at the level of L1 or 2. After that, these are the nerves that are extending down till the end of the vertebral column, and the usual spinal cord is the whole spinal cord as such is ended at the level of the L2. In children, in infants, it is occupying the whole length, but as the baby grows and as the person become adult, the spinal cord, because its growth is not as rapid as that of the vertebral column, so it remains at the level of the L2, or it extends till the junction of the L1 and L2. Now, uh, just before its end, it tapers down, and it forms a cone, and this area is called conus medullaris. This is the area where the spinal cord is terminated, and it takes the shape of a cone. Now, different nerves supply different areas of the body. Usually the nerves of the lower cervical and upper thoracic, they supply the upper arm, and lumbosacral area supply the lower limb. And there are different pathways for different sensations, and different pathways for motor and sensory bundles. The bundles that are taking the motor nerves, they are arranged separately as compared to the bundles that are taking the sensory fibers up from the lower part to the brain. They are in separate bundles within the spinal cord. Now, if you see this picture, there are the tracks. They are usually ascending and the descending tracks. The descending tracks are those that are coming from the brain towards to the peripheries or towards the extremities, and the ascending parts are, or ascending tracks are those that are coming from the periphery and they're ascending up to reach the brain. So we have the pathways, the dorsal pathways or the dorsal tracts. They are usually the sensory tracts, and these are the ascending ones. And we have the anterolateral tracts, anterior and the lateral tracts, which are the descending tracts coming from up downward. And then there are spinothalamic tracts and spinocerebellar tracts, which have their own bundles there. Now, The descending tracts or the corticospinal tracts, these are usually the motor fibers which come from the cerebral hemisphere, from the precentral gyrus, and then they come down and they first relay on the in the midbrain, and then they come down, they cross to the opposite side at the level of the medulla, and then they come down on the contralateral side, and then the synapse on the at the corresponding level within the spinal cord. And we have two corticospinal tracts, the anterior corticospinal tract and the lateral corticospinal tract. And both of these, they contain the motor fibers. Then we have the dorsal column or the ascending column. It contains the sensory pathway. We have two different nuclei within the midbrain for it, or within the medulla for it. The cuneatus fasciculus, that is the nucleus fasciculus, that is actually sorry, the nucleus cuneatus, that is actually taking the fibers from the upper limb. And then we have the nucleus gracile, which takes the fibers from the upper limb. So the nucleus gracile, it takes usually the fibers or the gracile fasciculus that is coming from the lower limb, and the cuneatus fasciculus is taking the fibers and giving it to the nucleus cuneatus, and it's associated with the upper limb innervation. There is another ascending tract, the spinothalamic tract, that carries the crude touch sensation. Actually, now there is a difference between the sensations also. The fine touch or fine sensations, like if you are patting someone, if you are touching someone, this is the fine touch sensation. And proprioception, the position sensation or the proprioception sensation, these are traveling in the dorsal column. And now, as they are traveling, they go straight towards their side, and then they cross the midline at the level of the midbrain. Now, at the level of the medulla, above the level of the spinal cord. And when we talk about the spinothalamic tract, they, on the other hand, they cross the midline at the same level when they enter the spinal cord. So there is difference between these two tracts. Both are sensory tracts. One is dorsal, that is going up and then crosses the midline, and the other is the anterior or the lateral spinothalamic tract, which enters the spinal cord, crosses the midline, and then it ascends. Okay, so why it is important to understand that it is the reason for difference in the sensation which they carry. The spinothalamic tract, it carries the crude touch or the pain sensation, uh, the pain stimulus or the temperature stimulus. They are actually taken up by the spinothalamic tract. So if they are affected on one side, keep it in mind that the problem is in the if they are affected on one side, you can think about the hemisection might be on the other side, because the level of the hemisection can be higher as compared to the area where you are feeling that deficit. So just yeah, we'll go into the detail after we'll discuss the syndromes one by one. Just keep it in mind that we have two spinothalamic tract, anterior and lateral, and they carry the pain and temperature sensation. The other P and T, the fine touch and proprioception, T and P sensation, the proprioception and the fine touch, they are carried by the dorsal tract, but pain and temperature, they are carried by the anterolateral spinothalamic tract. And the spinothalamic tract, it crosses the midline soon as it enters the spinal cord, but our dorsal tract, it synapses in the spinal cord and travel in the same plane, in the same section, hemi area, and it crosses at the level of the medulla oblongata. Now, clinical features of spinal cord compressions can be myelopathy, upper motor neuron signs because of the interruption of the inhibitory pathways. Upper motor neuron lesions are the lesions that are because of the uh, downward tracts of the uh, anterior and lateral corticospinal tracts. Patient may present to you with motor weakness, sensory impairment, and problem at the sensory level, and there is a cutoff sensory level because of the transactions. Problem may be in the imbalance because of the spinocerebral tract affection and bowel and bladder dysfunction, especially in the injuries to the lower part of the vertebral column, or the area that is below the level of the conus medullaris. Okay, clinical syndromes that we have here, they are the Brown-Sequard syndrome, uh, central cord syndrome, conus medullaris syndrome, and cauda syndrome. These all you have covered in your in anatomy, the neurology part of anatomy. So I'm going in just brief detail of it, and I have shared videos for these in your Moodle. You can check those videos, and it will be very easy for you to understand there. And I will also share the video with you, and hope it will help you in understanding the things. Okay.
Hi everyone, Dr. Mike here. In this video, I want to talk to you about something called lesion or damage to only one
I have
part
told you
of
what
the
is
spinal
the.
cord.
I have told you what are the different tracks that we are having. So we have one corticospinal tract that is coming from the cerebrum down to the periphery. So if you take if you take in mind this green one as the corticospinal tract, the fibers of the motor neurons, they are coming. Just a minute. Keep it in mind, this is the descending track, that is the motor one, and these are the two ascending tracks, the blue one and the green one. Now, sorry, the blue one and the red one. The blue one is coming in the spinal cord, it ascends, and then it synapses at the medulla, and it crosses the brain and goes to the opposite side. While the red one, it comes, it synapses and crosses the pathway. Now what happens, that if there is a transaction at the level of this, if there is a transaction at this level,
Spinal cord.
the spinal cord, what will happen?
May be noticed. So, for example, what you're going to find is this. On the same side of the lesion or damage, below the level of damage, there's going to be problems with, what's this blue line? Fine touch and motor movement, because of the pathway which it inhibits. But that hand, for example, it may not be able to move, it may not be able to feel fine touch, but if you put an ice cube on it or prick that hand, you would still be able to feel pain and temperature, because it moves down the other side of the spinal cord. But what that also means is, think about it, if we, obviously we've got a hand on this side, right? It means that if you superimpose these on the other side, on the opposing hand, below the level of injury, you will be able to feel this fine touch and be able to move the hand, but the temperature will be blocked. So then you won't be able to feel the temperature or pain on the opposing hand. And this is called Brown-Séquard syndrome. This is the reason why individuals who may suffer some sort of damage or injury to the spinal cord, but only damage.
Okay, so usually it is because of a hemisection or section of one half of the spinal cord at any level. Yeah, so it is because of hemisection or transaction at one half of the spinal cord. And what is happening? The sensations that were being carried out directly from there, they will be affected on the same side. But the things that were coming out and they cross the midline and go or traveled up opposite side to the lesion or to the transaction, they are usually affected on the opposite side. um, just a minute if I have it here. No, look at it. If there is hemi transaction of the or hemi section of the spinal cord, what will happen? There is a motor deficit on the uh, sorry, there is first talk about the sensation. There is ipsilateral loss of the fine touch and proprioception, but uh, on the same side or on the ipsilateral side, the pain and temperature sensations will be intact. But when we compare the other hand or the other side of the body, the pain and temperature of the other side of the body will be lost, but the weakness of the proprioception or the fine touch, they will be intact. The same is for the motor. The same side motor activity will be lost. So there will be ipsilateral motor loss, there will be ipsilateral fine touch and proprioception loss, but contralateral pain and temperature. This sequence or this syndrome is called Brown-Séquard syndrome, and it is usually seen in patients with hemitransaction of the spinal cord, usually secondary to uh, uh, direct penetrating injury, some knife injury or stab injury in that region, or sometimes with the bullet injuries. So clinical for what you call it. So usually we have it secondary to penetrating trauma. Then we have central cord syndrome. Central cord syndrome usually affects the mid to lower cervical spines, and a patient usually presents with quadriparesis. It affects upper limbs more than the lower limbs. The involvement of the upper limb symptoms, they are more. And what is happening in the central cord syndrome? It is actually maybe because of the degenerative changes in the vertebral column or in the um, um, lower edges of these vertebrae, the osteophytes, they are compressing the central part of the spinal cord, or it could be a disc prolapse or the vertebral disc anterior movement that is causing this syndrome to appear. You can see the detail of it in a video. I have shared a video for you in the Moodle. Then we have conus medullaris syndrome. Conus medullaris, I told you that at the level where the spinal cord is going to end, it makes the shape of a cone. And if there is injury to that cone, injury at the level of that area where this cone is present, the T12 to L2 region, it is usually characterized by symmetrical lower limb weakness. Excuse me, I will. um, Okay, so injury to this conal region or this conus medullaris, it causes symmetrical lower limb weakness. Both of the lower limbs, they are paralyzed or they underwent paresis bilaterally. There is bilateral sensory loss, and the sensory losses in the area of the uh, we call it saddle anesthesia, or the area where you sit, the area of the ischium and around that area, we call it saddle anesthesia. And there are also involvement of the lower limb, the leg numbness is also there. Then patient will have bowel and bladder dysfunction because the lower sacral nerves are also affected. So the bowel and bladder dysfunction will be uh, prominent here. Another thing, now this was the area which is called the conus medullaris, the area which ends at the level of the start of L2. Now, if you see beneath it, there are nerves only that are coming down, and then they come out of the this vertebral column, or what this spinal column, from the through the vertebral foramina. Now, if there is any injury in the area beneath the conus medullaris till the end of the vertebral column, the syndrome that appears is called the cauda equina syndrome, because this is the cauda equina, and the syndrome that we have by injury to this area below the level of the L2, we call it the cauda equina syndrome. And usually, patient presents with back pain. There may be symmetrical or asymmetrical limb weakness, lower limb weakness, and patient may have the same bilateral sensory loss or leg numbness, and there is incontinence also, bowel and bladder both incontinence. Now, the causes of spinal cord compression can be degenerative because of the age-related changes, because of the degeneration. These could be infectious. These could be neoplastic or malignant in origin, malignant or benign neoplastic conditions. This could be secondary to trauma, or this could be because of the vascular tumors or the vascular problems. uh, we have to differentiate these causes by detailed history and by a thorough physical and neurological examination, and then with the guidance of those history and physical findings, we plan for the investigations. Now, degenerative surgical spinal diseases, they are usually they have insidious onset, very gradual onset. They uh, there is ongoing improvement and progression over time. They may improve, or the problem may progress, and they usually affect the cervical, thoracic, and the lumbosacral spine. Uh, Pain and symptomatology depend on the level of the disease. What is the level of the problem? The symptomatology is depending on that level. Uh, Examples of these can be the spinal stenosis. You can see these as in the patients with facet joint arthropathies. With those arthropathies, the spinal cord or the nerve that is coming out of that foramen, it becomes compressed, and there is a degeneration in the spinal degeneration of the spinal cord as such. Or it can be because of disc herniation. With disc herniation and pressure effect on the spinal cord, there may be degeneration of the affected area. Investigation is by imaging. We go for MRI MRI of the spine to identify the extent, and to identify the severity of the condition, as well as the extent of the lesion. And management depend on the severity of the symptoms and the location of the lesion. We can treat it conservatively if the symptoms are not so severe, and patient can be advised special exercises, and to avoid certain specific movements. But in some cases where there are severe symptoms, severe pain, and uh, severe and pain and numbness of the affected limb, then we have to go for surgical decompression. We go for laminectomy or discectomy. We remove the lamina, or we remove the part of the disc. We call it laminectomy or a discectomy. And sometime, if there are problems in the vertebral column itself, and it is causing some effect because of its degeneration, we can offer vertebral fusion procedures also. That is to be discussed in ortho, so I'm not going into the detail of it. But usually, what is usually the treatment of disc prolapse? It is um laminectomy or disc discectomy, to cutting the disc that has been prolapsed outside and causing compression of the spinal cord after in front of it. Now, infectious spinal cord compression, because of the infectious, due to infectious problem or infections, it has acute or subacute onset. Usually, there is associated infection, but it is not necessarily. And usually, the dental procedures are considered as a risk factor for development of this blood-borne infection. Pain and symptomatology depend on the level. Again, as always, because in brain and the spinal cord, the symptoms are dependent on the neurological symptoms are dependent on the location of the lesion. Fever, rigors, and chills are not always present, and as these are usually the chronic varieties. Investigation is you have to go for a systemic workup, and MRI scan of spine is indicated to identify the exact location and the severity of the uh, compression. And management is we have to obtain tissue diagnosis, and antibiotics are started, and if needed, decompression is uh, advised. Decompression is done in selected cases. Neoplastic spinal cord compression. Neoplasias can be intradural or extradural. And in intradural, they can be intramedullary or extramedullary. Usually, these tumors, they are of gradual onset over the period of weeks or months. Uh, if you come across any such problem, you have to look for the history of malignancy, because these can be the metastasis. Pain and symptomatology depend on the level of the lesion. For investigation, we have to go for systemic workup and CT of the chest, abdomen, and pelvis, the CT cap, and spine imaging is also advised, and MRI is the best as usual. Management is after obtaining the tissue diagnosis, we can offer chemotherapy or radiotherapy, and if the compression is causing severe symptoms, we can opt for surgical decompression. Then traumatic spinal cord compression is usually secondary to trauma. It is acute in onset, and patient presents with mechanical pain. The logical symptoms depend on the level. For investigation, again, we have to go for MRI, and management is according to the ATLS protocol. For spinal injuries, we have to immobilize the spine, because if it is just minor backlash injury, it can convert into a complete transaction if not taken care of. And usually it requires a surgical intervention, and we can go for decompression and fusion. So this is all about spinal cord compression. It is caused by a variety of pathologies, and clinical history is the key to differentiate each of these pathologies. It can present in different clinical syndrome, and these syndromes, they carry different prognosis. Spinal MRI and CT is the imaging modality. Spinal is the best modality of choice, and CT sometimes we also go for a CT scan. And management depends on the severity of the symptoms and the pathology of the disease, especially in the cases of neoplastic tumors. And we have to go for conservative or surgical treatment. And sometimes in cases when there is malignancies, we have to go for radio or chemotherapy even. So this is all about spinal tumors. Any question? Any question? Anyone is awake in this class, or all are sleeping? Okay, at least one has answered. Okay, tomorrow you will have lectures on trauma, shock, and I think there are 3 topics for tomorrow. So we'll take the lecture tomorrow. Now, I will send you the scenarios of tomorrow's as well as today's lecture. Okay, and we'll discuss inshallah these on Wednesday in the evening time, in the afternoon time, after 1 o'clock. Okay, please inform all the other students that are not here in the class, and I will take the attendance system. All these are sleeping students, the rest are really sleeping, and these are Rayan, Facility, Ahmed Yahya, Amir Ghafari. Screen. Okay. Okay, assalamu alaikum wa rahmatullahi wa barakatuh. We'll see tomorrow, inshallah. I too take long time. I was sleeping if you are not sleeping. Okay, assalamu alaikum. Have a nice day. Assalamu alaikum wa rahmatullahi wa barakatuh.